Good morning. That was less than enthusiastic. Are we not awake this morning? All right. At this early hour, we have a very interesting presentation. Healthcare professionals and religion. That's enough right there, isn't it? Is this trail off limits? Our presenters this morning are Gail Geller and Charles Bosk. Joel Frater also collaborated with the presentation, but Charles will be the single presenter this morning. We'll proceed this way. Gail Geller will have 30 minutes to present, and then we'll take 10 minutes of questions. Charles Bosk will have 30 minutes to present. We'll take 10 minutes of questions, and when both have completed, then we'll have them up here together to answer questions for about 20 minutes.
Thank you. Good morning. My talk is going to be a complement to a couple of the talks we heard yesterday by Virginia Bartlett and Rolanda Johnson. They focused on how professionals see the needs of their patients, and I'm going to focus on professionals themselves and their own experiences and needs with respect to personal faith, their own stories about personal faith and the impact and role it's had on them. A couple of disclosures here. I really am not an advocate of a particular religion. I'm not even necessarily an advocate that religion has to be a part of interactions between patients and providers. The two sort of passions that are motivating my interest here are, first of all, provider well-being. So I am very interested in the personal integrity of healthcare providers and the threats to that integrity and the impact of threats to that integrity. And I'm also very interested in exposing secrets. The things that make me tick are sort of being able to have conversations about what other people might think of as taboo subjects. So that's what I'm going to talk to you about today. And I'm actually, in the interest of time, I'm going to go past the little background and go right to the methods. This is an empirical study. A couple of other disclosures. One is that this is very much a work in progress. So I really do invite and welcome feedback and comments and suggestions. And the other is I want to apologize for those of you who have never seen a p-value. There are actually a couple of p-values in this talk. But there are, I promise, many more words than there are p-values. So I think most of you will follow right along. So like Tina Harris's presentation yesterday, mine is focused on a very, very small component of a much, much larger study. We got a grant from ELSI a number of years ago to look at moral distress and suffering of genetic service providers generally. And as part of that study, we've been able to look at a couple of questions related to what we're looking at, what we're talking about here. One is, what is the role of religion in the personal lives of genetic service providers? And second, what is the impact of personal faith and religious values on genetic service providers' experiences interacting with colleagues, experiences interacting with patients, and on their own professional well-being? This is a mixed method study. I'll tell you a little bit about what we did in the overall study. We started out with focus groups that took place at the professional meetings, American Society of Human Genetics meetings, National Society of Genetic Counselors meeting, and the ISONG meeting, which is International Society of Nurses and Genetics. So we had focus groups of 3 different types of genetic service providers listed here. And we asked at the focus groups, what professional or clinical experiences keep you up at night? That's the way we framed the distress-oriented question. We heard verbatim from them Every single thing we heard from them, we then converted into a discrete item that we included in a survey. And then we surveyed a much larger sample of genetic service providers of each of these three types. And then we conducted in-depth interviews of a sample of survey respondents. We just recently finished the very last phase of that study, which is another series of focus groups. It's not up on this slide, but we presented our results to this additional group of focus groups, again, of these three types of providers, to sort of get some face validity from them and to solicit their input regarding recommendations for where we go from here. So as I mentioned, the question was, what professional or clinical experiences keep you up at night? And we really stipulated at the beginning of these focus groups that we're not interested in hearing things like being overworked and underpaid, the things that are distressing to all of us in our professional lives. We really wanted to hone in on what sorts of things make you gnaw your teeth at night when you're trying to sleep. Professional experiences. So I'll start out with a couple of quotes. This is a quote from a clinical geneticist that I think reflects a kind of distress with the profession overall. I was pregnant at 37, and it was assumed in the division that I would have an amniocentesis, and I chose not to do so. And I was really ostracized for that because they asked me the reason, and I was honest and said, that all I was at risk for was Downs, and I wouldn't abort a Downs. My boss decided that from that point forward I couldn't work in the prenatal program because I was obviously too prejudiced about my thinking to be able to be a non-directive counselor. I didn't make this up. We heard from a genetic counselor, again reflecting, I think, distress with the profession overall. A few years ago, a presentation was given by someone that I respect a lot, but in the talk, slides were presented that, in my opinion, made fun of religion and religious beliefs and beliefs of faith and how they might interact with who we are as counselors and what we do. It gave me the sense that in this setting and with these professionals, religion is undermined and sort of made fun of, and that is something near and dear to my heart. All across the board, it's like if you're smart and scientifically inclined and so forth, then there is no place for faith. This was another genetic counselor that expressed, I think, distress with patients, but also with herself, and I'll say a little bit more about that in a minute. A young couple came in for prenatal diagnosis. I was trying to figure out why they wanted it. She's only 26 or 27. Why does she even care? They didn't have any experience with persons with disabilities. They just still wanted to have an amnio. So I kept talking with them about the fact that there was no clinical indication for their amniocentesis. And the gentleman turns to me and says, "You don't want us to have an amnio." So I'm freaking out. But believe it or not, and I'm really condensing this genetic counselor is freaking out in this focus group. Believe it or not, I said, "Oh, well, I'm sorry to give you that impression. But, tell me more." And he says, "Well, you have a Clauder ring on, which means that you're Irish. And if you're Irish, it means that you're Catholic. And if you're Catholic, that means that you're pro-life. And if you're pro-life, that means you don't want me to have an abortion, and you think I'm going to have an abortion because of this amnio." And this genetic counselor, in telling this story, she was really shaking. And what she said was the most distressing part of this for her was that she was outed. That's the word that she used. That it didn't even occur to her that the patient would know the significance of the ring that she was wearing, and she thought she was a very competent non-directive counselor. And that patient sort of pressed the button that she'd been trying to hide through her whole professional life, and that was really the source of the distress. So as I said earlier, each of the stories we heard from people in the focus group was converted into a discrete item that we included in a survey. So these are some of the specific items that we included in our survey. How often have you, and how much distress was caused by having difficulty reconciling your own faith with being a genetics professional, feeling the need to hide your own faith or spiritual beliefs from colleagues or patients, feeling ostracized by the genetics community because of your personal beliefs, and feeling like your professional stance or behavior is not consistent with your personal values. These are things that we heard people say. We converted them into discrete items. I won't bore you with the details of factor analysis. There were 38 such distress-related items that we included in the survey, 5 of which had some relevance to religion or spirituality. So there were 38 that reflected many more things. I'll go over a couple of the others right now. We did a factor analysis, and this actually formed a nice subscale that we called personal value conflicts. And you'll see why later that I'm giving you this background. Another sort of area of distress expressed by these professional genetic service providers we called negative patient regard. And these are things like disliking a patient as a person, feeling angry at a patient, feeling ashamed at not being able to feel compassion for or partner with a patient. This also formed a nice subscale that we called negative patient regard. You'll see later why I'm giving you this background. And another one we called patient dread. You know, it's sort of fun when you do factor analysis to kind of name that factor. And we struggled with what to call this thing. There was a sense of, you know, sort of, oh no, there's that patient on my docket. You know, I want to run the other way. Worrying that every patient encounter has the potential to be difficult or painful, feeling frustrated about unreasonable patient expectations, worrying that the decision a patient makes may come back to haunt you. So, you know, these were actually sources of significant distress expressed by these genetic service providers. So I'll give you a little bit of survey results. Demographics, we always start with that. We had 214 survey respondents, which ended up being a 61% response rate. 72 of them were clinical geneticists, 82 genetic counselors, and 60 nurses. I highlighted in yellow just the sort of take-home messages here, which were that genetic counselors generally were significantly younger, were less likely to be married. Overwhelmingly, the majority of genetic counselors and nurses, not surprisingly, were female. And across all three provider groups, they were overwhelmingly white. And also we had some practice characteristics just to share with you. The genetic counselors were much more likely to spend much more time seeing patients. They were much more junior, you know, likely to have fewer years in practice than the other two provider groups. It's very clear for the nurses, at least, that this is a second career for many of them. These are nurses that got burned out as regular nurses and then developed a kind of subspecialty in genetics, and they tended to be in oncology more than anything else. Not surprising. So here's, I want to, ooh, this was not supposed to happen. It's hard to read. Can you read it anyway?
Sure.
Yeah? Oops. All right. I won't worry about it. Larry Churchill cautioned us yesterday morning about sort of measurement and methodologic challenges when you're doing research on religion and spirituality. Our measures of religion and spirituality were of two types. I think both of them are inadequate, but this is what we had. We had a measure of religiosity. It's a fairly commonly used measure. How important is it for you to attend religious services regularly? We were frankly surprised, given the sort of notion that there isn't a lot of room for faith among scientists. We were surprised that about 27% of respondents said that regular attendance at religious services were very important, and another 17% moderately important. We ended up sort of dichotomizing this variable. But a fairly sizable number of respondents thought that it was very important. The other measure of religion or spirituality was a measure of religious coping. When faced with a distressing situation, how often do you seek comfort in your religion or spiritual beliefs? And, 10% said very often, but another 23% said sometimes. So again, not an insignificant percentage of respondents actually sought comfort in their religious and spiritual beliefs. And not surprisingly, these two variables are highly correlated with one another, but they're not exactly the same. And that's an important thing. I'd love to hear what you think are the sort of different things they're actually tapping or measuring. So now we get to a couple of p-values. I'll go over this quickly. So what we did here was just look to see if there were actually differences by provider type in those two variables. And as you can see, nurses were much more likely to attribute at least moderate importance to regular attendance at religious services, and also were more likely to seek comfort in their spiritual beliefs, at least sometimes or often. That's the only take-home message here. So remember the personal faith conflicts items? So here are the frequencies. This is the sort of quantitative counterpart to what we heard qualitatively in the focus groups. How often have you felt conflicted about disclosing your personal beliefs to patients? 24% of respondents said occasionally or commonly. How often have you had difficulty reconciling your own faith with being a genetics professional? We were pretty surprised that 10% of respondents said that they did occasionally or commonly. How often have you felt the need to hide your own faith or spiritual beliefs from colleagues or patients? 14% said occasionally or commonly. Here the percentages start getting smaller and smaller, but I think the fact that they're not zero is important for us to be talking about. How often have you felt ostracized by your professional community? 4%. And how often have you felt some inconsistencies between your professional stance and your behavior? 7%. We were interested because this is what data analysts do. We looked at the association between our two religiosity variables and these personal value conflicts. And not surprisingly, we found that the more religious you are, or the more importance you attribute to regular attendance at religious services, the more likely you are to say that you have difficulty reconciling your personal faith with being a genetics professional, and the more likely you are to report feeling ostracized by the genetics community because of your religious beliefs. And similarly, the seeking comfort in religion or spiritual beliefs. The more religious you are, the more likely you are to seek comfort in your religion, the more likely you are to report having difficulty reconciling your personal faith with being a genetics professional, more likely you are to feel ostracized, and the more likely you are to experience inconsistencies in your personal stance and your behavior. This, as I said earlier, this is a work in progress. There are lots of other parts of the survey that we are sort of hypothesizing might be related to our two religion kinds of variables. We were actually surprised to see, at least in preliminary analysis, that there is not an association between those variables and comfort with grief in patient care. We would have hypothesized that more religious people would experience greater comfort with grief. Not related to greater comfort with uncertainty in patient care. And what I didn't describe is that our focus groups included not only the sort of negative questions, what experiences keep you up at night, we also asked the sort of more positive counterpart, what sorts of patient care experiences actually give you meaning? What makes you feel whole and satisfied in your work? And I certainly hypothesized that these religion variables would be associated in a positive direction with meaning, and was very surprised to see that they were not at all related to meaning derived from patient care. So, I mean, I actually think this gets back to Larry's question about, are these really measuring what are important to measure? I promise these are the last two slides with p-values. Here is where I want to sort of harken back to those two other subscales that I mentioned at the beginning, negative patient regard and patient dread. What we did find is that those who attribute greater importance to regular attendance at religious services are less likely to experience negative patient regard and patient dread. What's interesting about that is that it's sort of, it's hard to know what that means. I mean, it could be that more religious people are less comfortable admitting that they don't like patients, or that they dread seeing patients, or that they want to run the other way. Maybe they, in fact, do have a greater sense of equanimity in the face of stressful patient care situations. We don't know what that means, but there is this inverse relationship. And similarly, not similarly, this is where these two variables are actually tapping, they must be tapping different things, because there was no association between seeking comfort in your religious beliefs and experiences of negative patient regard and patient dread. There is, however, a strong association between seeking comfort in religious beliefs and experiencing these personal value conflicts. I showed you that in a slightly different way with the histograms. And again, it's not clear which comes first. You know, these are associations, it's not causation. So do they seek comfort in their religious beliefs because they're experiencing these personal value conflicts? Or do they experience value conflicts because they are more religious? We actually don't know. Perhaps of greatest interest to me, because I said earlier I'm interested in provider well-being, we did include a very well-validated measure of burnout in our survey. And we found that religiosity is inversely correlated, inversely correlated, with burnout. The greater importance you attribute to attending regular religious services, and the more likely you are to seek comfort in your religious beliefs, the less likely you are to burn out. And specifically what accounts for that, the burnout scale has 3 subscales called emotional exhaustion, depersonalization, and personal accomplishment, and it seems like the subscale of depersonalization accounts for the greatest part of this association. So there is certainly a role that religion seems to be playing for this subset, small subset of genetic service providers that actually helps them feel whole, if you will. So then the final part of the study, as I said, involved in-depth interviews with a sample of people who responded to the survey. And in that interview, one of the many questions we asked people was to tell us a story about whether or not they ever had difficulty reconciling their personal faith with being a genetics professional. So we were sort of trying to get multiple takes on this phenomenon. And the overwhelming majority of people we interviewed did not really experience this conflict. The majority of people were not terribly religious. Remember, something like, I don't know, a quarter of respondents seemed to express some attachment to their religious behaviors and beliefs. And of the people who did seem to hold some attachment to their religion, a small number of them, well, let me just tell you a little bit. So there were 54 interview respondents, 15 clinical geneticists, 25 genetic counselors, 14 nurses. What's important here is that the people who agreed to be interviewed were not systematically different in any of the characteristics you'd look at from the survey respondents overall. So this is a good sort of representative sample of the people who responded to the survey. So those who are not distressed by their religious beliefs offered three themes emerged that explained why they didn't experience distress. One is that they can keep their two worlds separate without any difficulty. Another is that they find a way to merge their two worlds. And a third is that they actually benefit from using faith in their work. And I'll give you a couple of examples of each of these. Those who are distressed by their religious beliefs gave stories about reluctance to disclose their personal faith to colleagues, feeling conflicted when seeing prenatal patients in particular, feeling that scientific advances and professional obligations require them to set aside their personal faith, and judging patients who rely on God to cope with adverse outcomes. So examples of ability to keep two worlds separate. This is a male clinical geneticist who said, "My personal faith is fairly liberal, so it has not been very challenging. More than anything, with what I do, my faith is reinforced. I think that they just work together for me. I do not feel particularly challenged. I've gone through times when I am challenged in my thinking about what I believe about terminations or these pregnancies where these types of conditions exist. I think I feel pretty comfortable that my faith supports my decision there." Finding a way to merge two worlds. Genetic counselor who said, I consider myself to be a religious person, but I had not thought to pray for my patients. It just all of a sudden came to me. They probably need it more than I do. I think when I am praying for them, I am praying for me to be able to give them good guidance and also for them to be able to make the decision that's right for them. I'm praying that I will not be pushing them in any direction, not be putting my values on their decision. But at the same time, it's almost a way of letting go of the feeling of responsibility and giving it to God. And then a nurse said, sometimes when you develop these relationships with these people, you get a hint about how their faith sustains them or that they have no faith to sustain them. People who have a faith, I think, even though it's probably not politically correct, are comfortable if you mention their faith and what kind of things they can do to help them through this thing. People who say they have no faith, have no beliefs, I don't believe, because sometimes when I would say to them, I will pray for you, and they would say thank you. And then benefiting from using their faith at work. Here's a genetic counselor who said, praying for this patient that you disliked helps you develop empathy for them. You're thinking about what they're going through instead of just drawing their family tree and working up what they're likely to test positive in. And another genetic counselor said, I usually pray. I find that when something is plaguing me, that is the best coping mechanism that I can use is to give it up and let God take it. If I get busy, I notice that I'm not praying, and I notice I'm not as good at what I do. And here are some examples of the people who did experience some distress. Reluctance to disclose personal faith to colleagues. Genetic counselor said, I do not say, meaning I do not tell my colleagues that I believe in termination. I do not tell them I do not believe in termination because I'm worried about people judging me for feeling like it would be immoral for me to have a pregnancy termination. I do not really express my views. Another genetic counselor said, I have told people in the past that even if I was to get pregnant, I might not do prenatal testing, and that was just a complete shock. You could tell by the look on their face that they thought that was crazy. So in some ways, I think that the way I feel is not necessarily in line with the way other people feel. Of course, as non-directive counselors, nobody would say anything about your views being wrong, but maybe it is just an overall feeling, and not necessarily personally, but globally as a profession. Feeling conflicted when seeing prenatal patients because they might decide to terminate. Or this was interesting to me, they actually might withhold their beliefs for fear of judgment. So this genetic counselor said, what bothers me the most is that sometimes I feel like when patients come in for genetic counseling, that they are very defensive in the fact that they would not terminate a pregnancy. I've had a couple of patients that were conservative in their religion or whatever, and they felt very uncomfortable even telling me that they wouldn't terminate a pregnancy, because they think our whole profession opposes religiously based decisions. Scientific advances and professional obligations require you to set aside your personal faith. Here's a nurse that said, I was born and raised Catholic. When you have seen scientists find things based on embryonic stem cells, and people do get better, but the other side is that we're killing life. For me, an embryo is a life. I cannot imagine doing that, but I want to be able to help people that are alive now. The distress the people in that field that have to work with it day in and day out must feel, they would have to come to an inner peace. And I'm sure that is what I would have to come to. My bosses would understand if I removed myself, but I want to stay involved in the science, and sometimes I worry that it's at my spiritual peril. If you could say, well, it's like going to work. I just have to shut that button down. It comes into my mind, but I cannot impose my beliefs on them because it's not fair, so I just have to shut it down. So this reflects this kind of conflict between feeling like your integrity or your professional behaviors are requiring you to do something that's at your own spiritual or moral peril on the one hand, or you have to just shut down what you believe. Judging patients who rely on God to cope with adverse outcomes. When situations come up that are bad for our patients, I tend to be frustrated by people who say, this is God's will, or we're going to pray, or this was meant to be, that kind of stuff. I respect it on an interactive level with them, but I hate it. I think it's wrong. And a nurse said, it was a patient who was coming for genetic testing results, and her husband was a minister. He was somebody who didn't appreciate genetics. He was a creationist through and through. Yet she wanted to be tested, but he was so willing to tell us that this was something God created and blah, blah, blah. I said, yes, but we're not here to discuss theology. I knew it would be difficult answering his questions in a respectful way, but also giving her what she needs. That was the whole issue for me, making sure that she got what she needed. I'm basically done. So the limitations of the study. I mean, I suppose I should say the strength of the study, I think, is that it's a multimodal study, and we really did take what people said in their own words and try to collect or enrich our data set with several different methods: survey, focus groups, deep, in-depth interviews. But as I said earlier, I really am not fully comfortable with the two ways that we measured religiosity. I do think that there's a real difference between religion and spirituality, as Larry defined in his talk yesterday morning, and I suspect many, many more genetic service providers may experience a sense of spirituality than religion, and we just didn't really necessarily get to that level. There weren't huge numbers of people who were experiencing personal value conflicts, which I suppose is a good part of the story, but the fact that there are even between 4% and 14% says to me that it's just too much. I'm going to run to my conclusions. Conclusions. A significant minority of genetic service providers are religiously observant and rely on their religious values to cope with distress. Some of them experience difficulty reconciling their religious beliefs with the expectations of the profession, are reluctant to share their beliefs with their colleagues and their patients, and feel stigmatized by their colleagues and the profession overall. Such conflicts do seem to be more prevalent in the prenatal setting and among genetic counselors, and providers who are more observant are less likely to experience distress from patient care and at lower risk for burnout. And I would say that it's really, really important to find a way to expose some of these secrets or to reduce the secrecy surrounding personal faith and religion among genetics professionals, particularly if we hold ourselves out as models of cultural competence. If we can't be open and tolerant amongst ourselves, how can we possibly actually convey that sense of openness and tolerance in the context of patient care? Couldn't have done this study without my colleagues who will be co-authors on this paper as well, Barbara Bernhardt, Ken Kolodner, and Ellen Miko. So thank you.
We have 10 minutes for questions.
Yeah.
I wonder if the people who are reporting that they feel ostracized by their colleagues may feel some pressure to provide things that they're not providing. For instance, if I am not giving a patient the full range of medical options, I ought to feel ostracized by my colleagues because that's not something that's appropriate for me to do.
Well, ought to feel ostracized?
Well, let's say if I am a genetic counselor and I'm not telling people that they can have interventions and that they can end pregnancies because I don't believe it's appropriate, then my colleagues ought not to approve of that because it's my duty as a professional to give the full range of options.
So, I mean, I actually, we didn't look at this, but my sense is that really doesn't happen. I mean, my sense is that the tenet of non-directiveness is so powerful in genetic counseling training in particular. And I certainly heard people say that if they have very strong feelings against something like pregnancy termination, they tend to avoid the prenatal context. So they'll become pediatric counselors or adult counselors. They remove themselves from situations much more likely than they are to really insert themselves in the prenatal context and try to make people make decisions that they think are right.
That's reassuring. Thank
yeah,
you.
I don't hear that.
Oops. Did you touch on did your data touch on interactions with or providers who cast themselves in the mold of the moral guider? I'm concerned that recently the American College of OBGYN has said that it's no longer going to be required that if someone doesn't embrace the prenatal diagnosis thing, that they no longer have an obligation to refer to an alternative provider. Did you pick up on any of those issues?
No, we didn't, and I think that Charles Bosk that's really a big part of what I think his paper is going to cover. We didn't.
Ed Lambeth, University of Missouri. I wonder if you'd share with us some of the possible ways you think you could measure religiosity. Of course, behind that question is the notion often expressed that it has so many different ways of being expressed itself that it's almost unmeasurable, and people don't know what it is, and therefore some are reluctant to do it, so they're having just the opposite, perhaps, feeling you. So could you share with us some of the ways perhaps you've thought about trying to measure empirically spirituality?
I think that the definitions that Larry gave yesterday are a very good way to start. So I do think that people think of religious as being associated with a particular set of behaviors. So attending religious services regularly. I know that Charles Bosk is probably going to refer to Farr Curlin's paper in the New England Journal of Medicine, and they have actually measured religiosity among physicians generally, and they used a measure. Another sort of common measure is not so much how important is it for you to attend religious services regularly. It's actually how often do you attend religious services. So, there are different ways of measuring actually what you behave versus how you behave versus what you believe.
I was trying to ask you to speak to
the spirituality part?
Spirituality, not religiosity. I understand that quite well. But how do you measure spirituality? What do you ask, or what sort of behavior does one do? And it's sort of like a squishy marble. My experience of trying to do that. What are you
We actually haven't done it. I mean, I think we would have heard many more stories, and I think we would have gotten many more than the 10% or so respondents that we heard acknowledging some attachment to religion if we had a variable that. Larry, can you say again how you define spirituality? It's probably not on the top of your head.
You're right, it's not on the top of my head. I think I would say just exactly what you said. That is, I think it's more difficult to measure. I think it's much less easy to formulate it in terms of a question. And I think it's the sort of thing that has to be discerned by sort of looking at patterns and by trying to understand the general orientation that people bring. And so I think it's a challenge.
I actually think that probably the best thing to do is to go through a process, a methodologic process, somewhat like we went through here, where you actually ask people from their own experience. So I'm looking within now. I don't consider myself a religious person at all. And I do feel like my sort of spiritual life is important to me. So what does that mean? So it means something like, appreciating that there are mysteries in life. There are things that I don't understand or can't make sense of. That there are connections between human beings, that we're not all like these discrete little atoms running around. I believe that there's some, and actually physicists are supporting this right now. So it's another whole branch of science that we can look to. But I think that there is energy, some kind of energy between people that actually affects the world. I mean, so I think it would be useful to talk to a bunch of people and say, what does spirituality mean to you? And actually go through a process like this, convert each of those items into a survey and sort of see what comes out.
I'm interested in how people express their antipathy to either people of faith or the faith itself. Do you have any data on that?
Well, I mean, we certainly did have a sense for genetic service providers who are not at all religious when they encounter patients who are. One of the sources of distress for them, see, this whole study was focused on internal distress.
I think I meant of their colleagues. How do they express their you describe genetics professionals feeling intimidated or uncomfortable expressing their faith in the professional environment. What are they getting from their colleagues who don't respect their faith? How do they talk about why they don't respect their faith in a medical community? What's going on there? Why is religious faith or spirituality unwelcome?
Well, I think what was implied here is a little bit like your comment, I think, is the presumption that twofold. I mean, one is that if you believe in creation, you can't possibly believe in evolution. So, I mean, it's Francis Collins, I think, is advancing this debate somewhat in his book, but there is an overwhelming sense, particularly in genetics, I think, that there isn't a place for faith. How could you be a real geneticist and believe in God? Because I think it's partly that, but it's also, I think, a fear that it will conflict with the tenet of non-directiveness. That if you hold religious beliefs, you will not be able to be a responsible professional with your patients, because surely you'll have to be inflicting your beliefs on them, and that's not what we do in genetics.
Could I just add that one of the quotes that you had up there was very clear about what was happening in the professional interaction. That is that colleagues were making fun of.
Yeah.
But why? What is the way it makes them uncomfortable? I think we forget that's what we mean by spirituality.
I would assume that just having something that's dear to you made fun of by colleagues, your own peers, is a hard thing to take.
No. She's saying, why are they making fun of?
Oh, that I can be.
No,
I think we're going to have to
go on.
honor the next speaker by calling this lively discussion to an end right now. Thank you.
Good morning. Folks have tended to start with self-disclosures of belief or not belief. And I think I'll do the same. And first, I think I must be more of a person of faith than I normally think of myself, because I find myself uplifted when I see a multi-method presentation that's so nicely laid out as that it's a kind of thing of beauty to be able to present something that complex in such a short period of time, that the oceanic feeling that Freud complained he never felt in Civilization and Its Discontents, I sort of feel when I hear a presentation like that. Second, I don't particularly practice any religion, and it's not because I got so good at it that I didn't need to practice it anymore. But I did grow up as an Orthodox Jew, and I pretty much feel that the lesson of World War II is that the state defines what my religion is, not me. And I would like not to lose that lesson, and I became a sociologist in some ways because when I first read The Protestant Ethic, I just didn't get it. I couldn't understand what Weber was talking about, because I grew up in a part of Baltimore where the real diner on which the movie diner is based, I could see from my bedroom window. And so I grew up in a community in which there were 4 different religious groups. There were Orthodox, Conservative, and Reformed Jews, and there were other. So I just didn't, so the Protestant ethic it was baffling to me. And I think I spent my first year of graduate school studying Protestant theology as sociological theory. And at the time I was in graduate school, the dominant sort of theoretic problematic that we were faced with was how to distinguish between science, religion, and ideology. I would like to say that we settled that, but I don't want to start with a lie. Second, I thought I had finished thinking about genetics about 15, 20 years ago, and I didn't really expect to write about anything in genetics again until this invitation came along, and I had sort of just assumed non-directive, value-free remained the ethos. So I started looking at conscientious objection. I found it bewildering, and like a lot of other things that I do, this has begun to morph into, this paper has begun to morph into a larger project that I didn't realize I was working on. And that larger project has to do with what is the meaning of the term professional or professionalism. When in sort of public discourse and policy language, the notion of a public good disappears, and all that's left is a marketplace. When you only have marketplace language, how does one begin to make sense of professional service, fiduciary responsibility, and the like? And I'm actually working on a series of papers around that. And finally, the last of the disclosures is the last thing Joel said to me is, when the question and answer period comes, just blame me. And in truth, I can't do that, but I was reminded of the administrator who, upon taking a role, was handed by the person he was replacing 2 envelopes. Said, and they were numbered 1 and 2, of course, said, when you reach your first crisis, open the first envelope, and second crisis, use the second envelope. So first crisis comes along, and he opens the envelope, says, blame me. Things go along smoothly for a while, and second crisis comes, he opens the second envelope, and says, prepare 2 envelopes. I'm hoping this is just envelope number 1. And I'd like to, I'm not going to use, this is an odd talk for me to give. I'm much more comfortable working from data and description to interpretation. And this is about the most judgmental and prescriptive paper that I have ever written or co-written in my life. And I want to start by being clear about what we are not saying and what we are saying, or what I will be saying and what I won't be saying. I do not want anyone to hear this paper as saying that there is no room for professionals to exercise and act upon their conscience. Of course there is. But what we are saying is that that right is, like most rights, a limited right. And it needs to be balanced against the rights of others, particularly the rights of patients to exercise autonomy with regard to reproductive freedom based upon the information necessary to make choice meaningful. And what is bewildering to me about the current way that claims of conscience are being forwarded is that they include this kind of extensive claim of conscience which says I do not even have the obligation to tell you what I'm not going to tell you, because that would be to act in complicity with a moral wrong that you are about to commit. So let me get started. A phrase that's never made sense to me after a couple of minutes of talking. Claims of conscience are not new in medicine. In some ways, I think if we took a slightly longer view, we could say that allopathic medicine owes its current marketplace dominance to a moral crusade against abortion based upon the Hippocratic Oath. That in some ways served as a way to demarcate allopaths from all of the competitors in a very crowded medical marketplace at a time when nobody could do very much good. So at that point in time, there was no superior therapeutics. There was only the claim of a superior professional conscience, and a lot rested on that. And you can, so it was this reliance on the Hippocratic Oath. And you can see the kind of professional code of ethics, professional code of conscience quite clearly in the commencement addresses at medical colleges that were often given by prominent clergy through the late 19th and even into the early 20th century, most of which emphasized medical work as a sacred calling. Now, I would probably then argue that throughout the 20th century, the locus of authority for allopathic medicine moved from the pew to the laboratory bench. As it did so, at least for us, those of us who take our Weber seriously, it created a slight moral problem because, as Weber says in Science as a Vocation, science can tell us what we need to do if we wish to master life technically. However, it can't tell us whether we ought to. There are questions of Weberian sobriety or pessimism, depending upon how you want to frame it, talks about all of the questions on which science is silent. Because you need, in order to figure out what to do next, refer to some other value system. By the mid-20th century, I think sociological definitions of the profession, of what a profession is, had solidified. And a professional occupation was marked by a long period of adult socialization in a body of specialized knowledge, and practice was marked by autonomy, and public trust rested on institutionalized integrity of the profession, which in turn rested on formal codes of ethics. And part of that code of ethics meant that the profession would be self-regulating and self-controlling, because only it was schooled in both the code of ethics and the formal body of knowledge well enough to apply and recognize deficit, and that would be guarded by, it would also be guided by a service ethic and a fiduciary obligation. Now, that's sort of the mid-century definition, and the rest of the century, by and large, was a long, protracted debate, somewhat tiresome even to those of us that engaged in it, about whether that original mid-century definition confused a political rhetoric that leaders of the profession used to gain, to be free from state interference with an empirical reality of everyday practice. And I don't want to go through, how that debate turned out. It sort of kind of just trailed off the way that I do it at the end of sentences where I don't have words any longer. But, the key questions remain: how much does a service ethic guide behavior? And how much does a profession exercise its social control responsibilities over the members of that profession? Now, what's important here is that there is a conscience that practitioners have. However, that conscience has the following characteristics. It is collective, it is socially shared, it's a communal possession formed and reinforced by passing through a set of educational rites, rituals, and ordeals, and it is avowedly secular, even if holy, in order to meet the demands of a complex, diverse, plural society. And what is peculiar, puzzling, and bewildering to me, and I must say totally unexpected, Joel was, at least in terms of when the invitation to write about this came, it was Joel that suggested the topic, and I actually didn't believe what he was telling me. It was one of the few times where I actually had to really go back and read everything that he was, really read the literature closely, because I couldn't believe it. It was astonishing to me, because the claims of conscience that are being raised today, first of all, it's not surprising that they typically are raised around matters of birth and death. If you expect claims of religion and conscience to be raised anywhere, birth and death seem like pretty likely places to me. But the claims are very different from earlier assertions of conscience, in that they are separated from the belief system of the professional community. They're not beliefs that are shared by all members that do this, all the people like us. Rather, they are beliefs that I have because I am a member of community X practicing profession Y, and as a member of community X, I can't do this. Now, I'm okay if we stop there. I actually think it would be a bad thing to coerce people to perform procedures, especially procedures that involve things like cutting people, if they didn't want to do them. However, I've always thought that there's a second professional obligation, which is to make certain that if you can't do it, you refer to someone who can. That if it violates your ethic and you believe in service to patients, then you are not their conscience, the keeper of their conscience. You're just the keeper of your own. However, the kinds of claims that are being put forth now are very extensive. They claim the right to refuse to disclose to the patient, the right not to disclose to the patient what you're not disclosing to the patient. That is, if you think it's against your professional ethic to provide a service, if that service is a legal and legitimate service, but you feel it's wrong, some notion of moral complicity means that you also have the right not to mention and not to refer, and I don't get it. I mean, I just simply don't get it. And I don't get it for a lot of reasons. I don't get it because it shifts the burden to the patient in a way that I'm not clear that the patient can pick up. That is, if we assume a expert who controls service and a naive patient, we don't even know what the patient doesn't know isn't being offered. And two, the kind of claim that's being made is it's the obligation of the patient to inquire of the professional before seeking care what the professional's values are, what that professional's values are, what that professional will or will not do. And specifically, the burden is to ask about controversial procedures. Well, how would you know that they were controversial if they are legitimate, sort of socially acceptable, and I'm trying to figure out exactly how it is that the professional tells you that, no, I don't do that sort of thing, in a way that doesn't make you feel like a moral cretin. That is, I'm trying to figure out the ways that are not demeaning, belittling, and judgmental and shaming. And I can't, I'm sorry, do it. And it strikes me that for most patients, the moment that you will find out, one person's extraordinary kind of out-of-bounds behavior is another person's kind of routine, unthinking, of course I'm willing to do that. So it's quite likely that the moment that you will find out that you've breached the professional's conscience is the moment that they tell you that we don't do that sort of thing, and I can't imagine that being a comfortable interaction. Beyond that, what does a service obligation mean? It's a matter of where one draws a line in the sand. And as I read the history of sort of doctor-patient relations over the last, let's just say the few years that I've been studying it, which are many more than I would like to admit publicly, that the entire drift has been towards leveling the playing field and allowing patients choice. So I have to wonder what in the world is going on that, in fact, people whose work that I otherwise respect seem to be rolling back that choice without a lot of consciousness that they're doing so. That is, without recognizing the enormous asymmetries of power, access and control, social and economic capital, knowledge and information that exist within the sort of professional lay-client relation. So for me, a minimal definition of a professional acting with respect to a client and acting with a minimal amount of respect for that person's autonomy means not blocking access to legitimate services. Now, you may not believe the services are legitimate, but if the society has, then it's not clear to me why you should have a moral veto over what the collective has decided. So the extensive claim of CO, it seems to me, is itself actually, I'll use the strong word, I think it's immoral, essentially. I mean, I just think it shows a lack of respect for the patient, and I think it doesn't recognize the integrity. It recognizes your integrity, but not the others. And I think that decency in human interaction requires that each party recognize the integrity of the other and the right to disagree, not to short-circuit a discussion by silence, which is what I really find objectionable. And then when I think about conscientious objection in American society, I usually associate it with civil disobedience. And when I do so, I think that the dramaturgic, it's not going to be that long, the dramaturgic force of civil disobedience comes when, out of conscience, you disobey what you believe to be an unjust law in order to accept a public punishment that will draw attention to the unjustness, the oppressiveness, the unfairness, the wrongness of the law itself. But it seems to me that people now claiming this extensive claim of conscientious objection are asking for a free pass. That is, they're willing to bear no burden, pay no price, accept no sanctions for that conscientious objection. And I would think that if the ACGME is going to say systems-based knowledge and professionalism are two core competencies that all that practice in a profession must possess, then there needs to be a collective discussion about how conscientious objection and in its extensive form gets handled. I don't know if we have to go to baby doe kind of signs in reproductive genetics clinics that says you have the right to the following. Here's an 800 number to call if I don't know exactly what the solution is. But the claim unchallenged is not a resting point for me. And I keep thinking of Martin Luther King's letter from the Birmingham jail. I keep thinking, those are very forceful words, but would they have the same power if they were titled The Letter from the Birmingham Public Library? And I think not. So this kind of extensive claim of CO, conscientious objection by healthcare professionals that goes unchallenged, unquestioned, and I just can do it because I'm a person of integrity and you can't ask me to violate it, is horribly one-sided. And the imbalance is this. It's my rights to act on particularistic grounds in order to deny another constitutionally guaranteed liberties, which to me are more universalistic grounds. And if I have to choose between the particularistic and the universalistic, it's not for me a hard choice. Now, I have, I hope, overstated the paper about as much as I can because I rarely feel myself outraged by a literature that I read. But this was a time when I was literally slack-jawed that I can't find a test that I can't find a difficult test for conscientious objection that's put forward in the literature other than that one's belief that one's acting on conscience be plausible. And I would like a stronger test than plausibility, especially when the denial of the rights of others is involved. Thank you.
We have 10 minutes for questions.
Got a mic here.
Oh, okay, sorry.
Okay. Lori Williamson, genetic counselor, University of Oklahoma. I just want to add to what you shared from your review of the literature, a practical application, unfortunately, of that, of what you've been reading. Oklahoma was the second state to pass and enact licensure for genetic counselors recently. And a national group, not part of Oklahoma legislature, added an amendment to the bill that would prevent a genetic counselor from being penalized for conscientious objection to, of course, they were referring to abortion. And I'll have to go back and now, listening to your talk, read the statute more carefully and see what else it says about, does that person have to refer to another professional so that the patient receives all of the information, or can they just not give that information and nothing can happen to them professionally in terms of their job? That was the implication of that amendment, but I don't know. Now that I've listened to this, I'll have to go back.
It's the notion that, in fact, providing information is to be morally complicit that is what made the little hairs on the back of my neck stand up.
Chuck, as you may know, I'm something of a groupie, but I rise to disagree. I should begin by saying that I'm entirely uninformed of the literature you're responding to. But all I know is what I just heard, which seems to me to be built on the premise that a genetic counselor is not a moral agent, is not responsible for any of the things that happen as a result of his or her statements, and could never be complicit. Where, of course, it seems to me that's just transparently false. It seems to me wrong to suggest that a genetic counselor should report all information, no matter how certain or uncertain. And that's what it seemed to me the talk suggested.
No,
I'll finish and then I will shut up. So that if your talk is aimed at a much more discrete and limited body of literature, I think it would be really good not to be so abstracted about it and pull it right out of the closet and say very explicitly what kinds of arguments you're responding to.
The argument I'm responding to is that to even inform patients of what tests are available, what reproductive options are available, what testing is available, to let a naive patient who doesn't know those things is to be morally complicit because of where knowing that information might lead. So it's the reason I took the position that I did is that it seems to me that on the other side of the table is a patient who has fundamental liberty, personal autonomy, fundamental to any schema of ordered liberty, to quote a justice. There's been a flurry
of papers lately by Farr Curlin and John Lantos and several other people. By way of background, Farr Curlin, I don't know what John Lantos' personal beliefs are. I know that Farr Curlin is a fairly conservatively religious person, but they are making the argument that conscientious objection is a valid claim for healthcare providers to make. They're not specifically talking about the genetic context. They're just saying, in general, we haven't paid enough attention to objections on the part of healthcare providers based on their religious and moral beliefs to being asked to do what they want to do. So this is, I mean, I think that Chuck and Joel are reacting to that flurry of literature.
Now, we are definitely reacting to that flurry of literature, but also I'm looking here because I pulled it out. I was going to actually, if I had time, read it. One of the things that's astonishing to me is there's this survey of from that FAR did that where on the basis of the survey from all the empirical is they draw a normative ought, and I couldn't figure out how in the world they did that. But the claim is made, this rather extensive claim is made, that not only, here we go. No, it's not here we go. But there's claim, in the letters to the editor that follow this flurry of literature, it's not only do I have this extensive obligation, it is my duty to prevent my patient from making choices that might be harmful to them or morally wrong. So I am not claiming that people cannot act on conscience. I'm just claiming, and in fact I think they ought to act on conscience. I'm just claiming that conscience does not extend to blocking people's information to their patient's ability to act on their conscience. That is, you can't, it seems to me, preserve the integrity of your choices by denying someone else the integrity of theirs. So you're free not to do what you think is wrong. But you are not free not to let people know what options they have. You are not free not to let people have the information on which to make informed choices.
I think specific examples would really help. I don't recall them before now.
Okay. I mean, there are specific examples.
I have no problem.
I mean, there are specific examples in the paper, which I now see I should have provided. I had a long talk with Joel the other night about his work as a palliative care physician. And he was describing two very difficult cases in which he thinks the right choice, both the morally right choice and the medically correct choice, is to discontinue life support for two infants who are going to die sooner or later. And so I asked him, I said, well, why then don't you conscientiously object and exercise your professional right to do what you think is professionally necessary? And he says, because I can't find a way to think that my judgment, I know what my judgment's based on, but I can't figure out why it should override the parent's decision-making capacity in a context in which sort of law, tradition, and sort of, the kind of general thrust of autonomy gives that decision-making power to the parents. So I won't. Others would disagree and say, well, you have an obligation not to waste scarce collective healing resources. And he says, I just can't do it. I can't claim that my judgment is, I can't claim that they believe in miracles. I can't believe miracles. I can't claim that I've never seen a miracle. I'm reminded of Roy Blunt being asked if he believed in infant baptism, and he said, believe in it, hell, I've seen it.
I was just going to make another argument in support of your position, which is that it strikes me that those of us who, in the professions, actually are voluntarily there And so as against our patients who, by and large, don't voluntarily have the problems that they're coming to see us with. I think that when you become a professional, you buy into, limits on your ability to say no. And so that's another argument that I don't know that I've made that in print, but I've certainly made it in public over the years.
We, in the paper, point out that the way specialty choice works is, by sort of self-selection. So if, in fact, your integrity demands that there are things that you can't do, then maybe you should choose a specialty where those choices are less involved. But I think it may be working the other way, actually. That, in fact, those with strong personal objections are going into the fields in order to impose that sense of right. I just don't have the empirical data.
Chuck, thanks for the talk. And my question is one of something like this. As a sociologist, what do you make of the privileged position that conscience occupies?
What I've been trying to figure, here's what I've been puzzling about. It's kind of the clinical question of why claims of conscience now? And I'm beginning to think of them as a screen for a system in which professionals feel pushed around, unable to practice in ways that they want to practice, and that the claims of conscience have the resonance that they have now because the professionals in those systems have lost so much of the autonomy that they have, so that there's a kind of, I really want to be able to act on my beliefs. And then there's not an examination, a close examination of the contexts in which the claims of conscience are actually raised. Because the desire to say, this is a broken system and we need people to stand up and fix it is a very powerful claim, I think, at the moment.
This is the last question.
Thank God.
Timothy Jackson, Emory University. I think you've put your finger on a real pinch, but doesn't it depend on the gravity of the wrong? Meaning, don't we really have to look at examples? For example, if I'm a businessman in 19th century Lexington, Kentucky, and someone comes to me and wants to sell me slaves, if I consider that to be a profoundly wrong institution, surely I wouldn't say, well, as a businessman in the ethos of the profession, I can tell you where you can sell them, but I won't buy them. Isn't there really, one, a question of the gravity, but two, isn't it probably prudent to err on the side of conscience? I mean, I see the point about a kind of sanction-free exercise of conscience, but I think, as Hal Berman used to say, the first principle of Judeo-Christian jurisprudence is the right of conscientious resistance or objection, because we don't want the state or even any large institution to be that coercive of conscience. And finally, wouldn't someone who repeatedly refused to do certain procedures in fact bear a price? People wouldn't come to them anymore if it were that controversial. But the point is, doesn't it depend on the gravity of the wrong? And isn't there a plausible case to be made that we wouldn't think you ought to be complicit in something like slavery? If you think abortion's unjustifiable homicide, it's going to feel like the same dynamic.
I don't buy the analogy. It seems to me that reproductive autonomy and slavery are really quite, I just don't get it, and I'm sorry that I'm that morally insensitive, but I am. And I understand that there, it may be that the long judgment of history says that the position I've just taken is the one is the one of the businessman that tells you where down the street you can buy a slave, and I'm willing to take that risk at the moment.
I'm going to invite Gail to come up now, and we have about 20 minutes for discussion.
Can I actually want to say something about this. I mean, I think one of the points that hasn't been explicitly made yet, although I think you alluded to it, is the idea of the power imbalance in the medical profession. And, you know, the concern, I think, that certainly that Joel has, I imagine that you do too, is that because of the powerful position that healthcare providers are in, there's almost a, err on the side of enhancing patient autonomy, almost as a way of redressing the power imbalance and not taking advantage of the power imbalance. That if you're withholding information that the patient has a right to have, then you are actually even inflating the power that you start out with. I'm finding myself actually having a little bit of reaction to your example that of Joel's with the ICU. I think that perhaps we've overstated the power imbalance a little bit, that there's a little bit of almost reverse hubris or something in the idea that he can't, he's not here to defend himself, he can't tell patients what he happens to think of as wrong because they will definitely do what he thinks is right. That's the sort of the assumption that his power will actually end up being what...
To report the conversation fairly, I disagreed with him. And asked him what was going to happen. And he says he has told them that what he thinks they're doing is wrong. And I said, well, what happens next? He says, well, I keep telling them. We keep the conversation open.
Right.
But what I can't do is beat them into submission.
Right. Sure.
And in medicine, it truly is the case that talk is cheap, and care is expensive. And so he's actually making a choice that probably the folks that run his institution might be unhappy with. And when it comes time to looking at that tub on its own bottom.
Perhaps I could come back to a less abstract example, and that is the American College of OBGYN. And I believe what they have done, they have modified either their credo or some part of the board examination so that applicants no longer have to adhere to this principle of if they desire not to deliver information or service for someone who is asking for prenatal diagnosis or intervention, that they no longer are required to refer them or make them have another alternative provider. And this is a national professional society, and it just struck me as sounding very different from what I am used to hearing. And I teach medical students, and I hear that attitude in medical students. And in the past, I was able to say that here's a principle to sort of guide you, and no longer can I tell them that that principle is recognized.
The question that I got asked, the question that I got asked in an early draft of this paper is how does one square a principle like the one you just enunciated with the wrongful birth suits? And the answer I had for that was, I don't know. But it seems to me that it's a principle that asks for legal trouble down the line, in addition to, I think, being wrong. I mean, just not to be too flat-footed about it. Well, to be too flat-footed about it.
I mean, I don't know if this is sort of related to what you were saying, but I was shocked to hear recently that OBGYN residents are not required to learn how to perform abortions, and that the actual technical skill is disappearing. And it's not always based on moral objection. And there are people who say, I just don't want my clinic to be bombed. I don't want to be at risk of being perceived as being pro-choice. And so I'm not even going to learn that. I think that is scary, that given that abortion is legal and ought to be available somewhere to women who want it, the idea that there aren't going to be skilled people to perform it eventually because no one's required to learn how to do it, that's troublesome.
I had, for a minute, just want to go back to the analogy that Tim made. And tell you, Chuck, that there's an even stronger argument why the analogy doesn't work, which is that in your case, the two people having this exchange have relatively equal power. It is the person wanting to sell the slave and the person who's a businessman are peers in the marketplace. And the person wanting to sell the slave knows perfectly well that there are other people who are going to be willing to buy if this fellow says no. But the patient in an OBGYN practice is not at all in that situation, has no knowledge of what the condition is, either that she is in, and has no knowledge of what the alternatives are for her. So to deprive her of the knowledge is to do something quite different than to deny her the service. You can deny her the service, but in the old professional ethic of, which I think is even written down, you're required to refer her to someone who will give her the knowledge. And now, apparently, you're no longer required to refer.
Yeah, abandonment. Patient abandonment used to be a professional wrong. And there's a sense of abandonment, I think, in some of this.
I just was struck by the example you used with your colleague, Joel, and his unwillingness to essentially defy parental wishes. I would think given the long history of parental autonomy, general autonomy with respect to treatment decisions about children, but it's quite interesting that the Houston policy on medical futility, which was multi-institutional, one of the three particularly egregious cases that ended up provoking that policy involved neonatal care, where all the caregivers thought it was unreasonable to continue the full court press, and it led, as I recall, to sequential amputation in the neonate, with 3 limbs now gone, but the parents still praying for a miracle. That seemed to me a particularly egregious example of what all considered a violation of professional integrity. So I think the missing link here is then some real advocacy on the professional's part to work hard for precisely that kind of policy, which would allow medical futility to be invoked.
I wanted to contribute something similar to what Andy has just presented, because I think that the reproductive cases that we're talking about, or where even where pharmacists are soliciting legislatures so that they don't have to prescribe medications that prevent the implantation of fertilized eggs, is different than the cases particularly of neonates at the end of life. Because I think that Joel's making the right call, because we don't have a uniform way to apply criteria in those cases, which is a part of what I think Andy was appealing to. So if we're going to say we're going to share responsibility at the beginning of the care of the neonate, I don't think we reach a point where somehow we're still not sharing the responsibility. Although there are cases that happen where you can say, we will no longer treat, you're going to have to find some other place that will. And again, it's a matter of continuing to stay in conversation and inform people about what their options are and what your institution is willing to do. But to figure it out case by case makes the most vulnerable person, the one that you're sort of exercising your own judgment on?
It's the notion that conscience allows you to withdraw from the conversation, and that troubles me almost more than the rest of it. I mean, it's the notion that because I have a claim of conscience, I no longer have to speak to you or inform you or even spell out what my claim of conscience is, that I find almost annihilating of the other. And I just have trouble with that.
Larry?
Well, I actually want to say something.
sorry.
Ask a question about one of the statements that I can't remember which of you made, that this is a relatively new phenomenon to pull out conscientious objection. I don't think it is historically. I think in terms of even in medical practice, I mean, a person's conscience, in the Western moral tradition has always been of pretty central importance, first of all. Secondly, it might not be that suddenly all these, whatever you want to call them, conservative Christians, evangelicals coming out of the woodwork suddenly wanting to assert power and authority. It might be that the technology has now shifted such that new problems are being presented to them in such a way that is problematic. Now, I'll give you one example of where I had a patient come to me, and we had a great conversation. He was a professor at one of the local universities, and we were chatting. It was going great. I did his physical exam, first visit I ever met him. And as I was walking out the door, he said, "Can we talk for just 1 minute? I'm a member of the Hemlock Society, and when it comes to it, will you be willing to write a prescription?" And I legally speaking, I had an out, right? It's illegal. But I can imagine a time in the future when it will be legal, where now suddenly here I have my conscience, and suddenly now I'm required to maybe not do it myself, but to refer him to someone who does. So maybe it's that the technology and society is shifting in a way where, and medicine is rather a conserving sort of tradition. Therefore, it tends to be more conservative and not like change. So maybe that's what's happened.
Actually, what I thought I had said was that claims of conscience aren't new. What's new is the basis for these particular claims of conscience and their detachment from the professional code of ethics and their referral to something outside. Your Hemlock Society thing is interesting because I actually think that problem's been solved by hospice, which is outsourcing the Hemlock Society to the home. And I'm just speaking for my father-in-law just died this fall, and I was really quite astonished. I mean, it hadn't, and I'm a sociologist, I should be able to figure this out, hadn't occurred to me that home hospice was just simply a transfer of decision-making power. Once you get permission from your physician to contact the hospice, then you're kind of flying on your own. And so in some ways, there's already, that workaround's already happened in some places.
I was going to make two very quick points. One is that I actually think that this is that what we're seeing with the emergence of CO, as you say, is actually a reemergence, and that in fact professional norms until the 1950s with the rise of informed consent, in fact embodied and embraced physician conscientious use of conscience. And so I think
but on religious grounds, that's the question. Clearly, the example of futility, you can think that something is harming somebody, and on grounds of, do no harm. I don't want this person to suffer. I'm conscientiously objecting. The question is it strikes me what's a little bit new maybe is the emergence or reemergence really based on religious grounds, because that's what Farr Curlin's paper is.
Well, I'm completely made nuts by Farquharson. Let me just say that. And I've heard him talk, and basically the last talk I heard him give is that he basically thinks that if there's anything that he has a conscious religious objection to, he doesn't have to do it. And in fact, it is immoral to make him talk about anything that he doesn't want to talk about. It's an astonishing view for a physician to take, I think. What I would say is that actually the notion of religion in our culture has changed so dramatically in the last 50 years that probably what I would say previously is that, in fact, that was just sort of that religion and other objections simply were not viewed as that distinct. And then that distinction has become much more salient in the last 60 years.
I think too bluntly dealt with in this paper is the fact that once professional codes of ethics jogged along fairly well with established, kind of religious elites,
right.
And it's the separation as medicine separated from religion, as the code of professional ethics became more and more kind of, let's call it evidence-based for the moment, now the claims reemerge, and what was once an invisible linkage now becomes a separation. And so the claims look new.
I agree.
Okay.
The other point I was going to make is that actually this issue of conscientious objection emerged in one of the very earliest wrongful birth cases. Actually, when I wrote my law review article about genetic counseling in 1978, and my editor, who I now realize probably objected to this, required me to write a section on conscientious objection in 1978. But pretty interesting. But actually, an intermediate appellate court in New York actually had to address the issue of conscientious objection in 1978 in a really early case called Carlson's versus Guarino. So this has been right on the table ever since the beginning of those lawsuits. Just thought I'd share.
Well, let me try again, if I may, if we don't like the slavery example. And many don't. But consider the baby doe case, right? Consider a child that's born with a tracheoesophageal fistula, has a duodenal atresia, also has Down syndrome. As we know in that case, the physician said, you need not operate. You need not do what would be medically indicated for anybody else and fix the fistula, fix the atresia. But let's imagine that I'm actually the attending physician. And I think that would be both a breach of medical ethics and simply murderous, right? You're letting the Down syndrome dictate what you do and withholding something medically indicated. But I know my colleague is a fan of Peter Singer, who believes that parents ought to have a 30-day probation period during which they decide whether they want a child. And if it's sufficiently handicapped or for whatever reason, they should have the right to infanticide. Am I obliged to refer this family who's coming to me for information that there is this option? And again, the point is, I feel the pinch, but I think, one, it depends on the gravity of the wrong you consider in the offing, and two, don't we want to tend to err on the side of protecting conscience against collectives? And again, this is an inflammatory example, but it actually happened. Right? The baby doe child was quarantined, nothing by mouth, starved to death. If it were under my care, I sure as hell wouldn't refer that family to a physician who's a fan of Peter Singer.
But I would then argue that, in fact, what happened after the baby doe case, the response to it, was collective, social, and in multiple ways very much reinforced the norms that you're talking about. Professionals are not isolated monads. They practice in communities, they work in organizations, they have colleagues to consult, there's conversations to be had. The unexamined claim that the right to claim conscience and have it neither be discussed by anybody else, known by anybody else, is really what's being claimed here. An unexamined right that the community does not have the right to inspect, that others don't have, which I think blocks the articulation of professional norms, blocks a serious discussion of where lines and limits are, and blocks our ability to disagree with one another civilly. What it does is it polarizes. And we have enough forces that are acting to polarize that we don't need one more, essentially.
We have two last questions, Mary.
I'm not sure this is a question. I've just been listening to this conversation in somewhat amazement that we've managed to have it for these long 20 minutes or so without mentioning the fact that we have just been living through 8 years of a political administration in which the Christian conservatives have had more of a voice than ever before, at least in my knowledge of American history, which has shaped countless decisions, judicial appointments, developments in medicine and technology in a highly inflammatory way, perhaps reaching its apex with the Schiavo case, to which those who watch these things have said since that time the role of the Christian conservative voice in politics is probably retreating a little bit, that many Christians of all stripes have been quite upset at that overreaching by political officials in interfering in that case. So I'm just curious, as we talk about this, as we talk about conscience, we're talking about values, ideas about spirituality again, about religious claims, which refer to a deity about which there is really no data. And how far do we want to be able to push that politically? And I think that we need to find a language so that we can talk about conscience, spirituality, political use of these kinds of values, be they culturally embedded for so long that they are something that we all take for granted, or are they capriciously used for political interests and something that we need to be intensely critical of. But we need to talk about this. We can't have this conversation devoid of the political context in which we're all living and some of us are suffering. End of comment.
I want to raise another question which we may not have time to go into. I'm often one of the slower kids on the block, and it's taken me a while. And I apologize for a first comment that may have been a bit off target. But let me raise the question of the professional ethic of genetic counselors, which, at least in public perception and in many comments here, is described as value neutral. And I thought I heard at the beginning a real claim that that's what it should be and must be. And I wonder to what extent you guys think that's right. Just to take some quick examples, are counselors obliged to provide counseling service and information in cases where the clear goal is sex selection? Are they required to provide information about non-paternity? Are they required to present information about speculative materials being worked on in the lab associated with their clinic? None of these is a new issue. My own view is that at points like that, the professional conscience might intervene, and it's not just you ask, I'll tell. But I'm very curious, really, as to where you guys are on that.
I actually, perhaps more than whether value neutrality ought to be a deeply held tenet, I actually think it's impossible. So I am of the belief that it's not really, that value neutrality doesn't really, I think that there is a tremendous amount of energy spent in trying to withhold one's personal values. As the genetic counseling example of the woman who's wearing a claw to ring, what upset her much more than their decision to have amnio was that she was outed. So I think genetic counselors go out of their way to uphold the professional obligation of non-directiveness, I think, to a fault. Because I frankly don't think it's what is necessarily in the patient's best interest. We certainly know that patients often ask for guidance from their providers. I'm agreeing with Chuck that the problem here is in not being explicit about what your values and beliefs are, for fear that if you express what you believe, it will influence people's decisions unduly. I think that phenomenon needs to be examined. I am not persuaded that if we were able to have an open, honest conversation, acknowledging that there are differences in values and beliefs, and what you decide to do is absolutely fine with me. I mean, your decision is your decision, and this is what I think, and this is how I feel about it. That's where I think genetic counseling ought to be headed. And this notion of non-directiveness really is very specific to it grew up in the prenatal context. So it's been applied to other contexts, and we definitely know in the cancer genetic counseling context, it's really not appropriate that people come to their genetic counselors seeking advice about whether they are appropriate candidates for genetic susceptibility testing, just the way they go to their doctors seeking advice about whether they should have a mammogram. It's over. There's been overreaching, and more and broader application of non-directiveness than is appropriate. That's my view.
And a long time ago, I think I spent a lot of time showing how people that were committed to, who said they were non-directive and value-free, used language in ways when counseling that signaled the opposite in conveying risk information. So, I've never...
It's the examined life, the examined encounter that I think we're after.
Yeah.
Would you join me in thanking Matt?
We'll take a quick